Well, as a clinician and a scientist, I feel one of the major messages is that we should be aware that we live in a capitalist society and that corporations are set up to maximize profits. I think that it's incumbent upon every prescribing physician to weigh the risks and benefits.
Hello, and welcome to the American Society of Nephrology podcast series, Convergence, a historical assessment of kidney diseases, nephrology, and health policy in the United States. I am Andrew Cohen, Professor Emeritus of Medicine at the Warren Alpert Medical School, Brown University. Thank you to the American Society of Nephrology and my co-creator, Todd Ibrahim, ASN Executive Vice President, and our spectacular producer, Catherine Buckler. Today's topic, the development of recombinant erythropoietin and the respective roles of government, big pharma, and the nephrology community. To discuss this, we have with us Drs. Kimmel, Coyne, and Singh. Dr. Paul Kimmel is Clinical Professor of Medicine Emeritus at George Washington University. Recently retired Program Director in the Division of Kidney, Urologic, and Hematologic Diseases at the National Institute of Diabetes and Digestive and Kidney Diseases, Dr. Kimmel is now the author of the recently published The Body's Keepers, A Social History of Kidney Failure and Its Treatment, in which he's written a comprehensive chapter devoted to today's topic. Dr. Daniel Coyne is a professor of medicine at Washington University School of Medicine and director of hemodialysis, Chromalloy American Kidney Center. His research has centered on anemia management and defining the risks and benefits of aggressive treatment of anemia in CKD and ESRD. Dr. Ajay Singh, who is Associate Professor of Medicine and Senior Associate Dean for the Master's Academic Affairs in the Office of Graduate Education at Harvard Medical School, led groundbreaking studies in anemia of kidney disease, including the Choir study, as well as being a member of the steering committees for the Treat and Drive studies. Paul, your chapter in your new book was really a tour de force in describing how all of this came about. Tell us a little bit about how recombinant erythropoietin was developed, starting with that meeting on the beautiful Isle of Capri.
Thanks, Andy. Capri was a great conference, and it was important because it was one of Joe Eschbach's presentations before his publication of the data on treatment of patients with erythropoietin in 1987. That conference was in the summer of 1986. But I just want to think about what the state of the health of dialysis patients was in 1985. So to make a very, very long story short for people who don't remember that era, patients were almost uniformly anemic. Some were so anemic that they would have hematocrits of 14, 15%. And I saw many patients who had 2 units of packed cells transfused every 2 weeks. And I'm sure you saw the same thing, Andy. The problem with transfusions was that there were complications of hemochromatosis and infections with hepatitis and later with HIV. And treatments besides transfusion were quite suboptimal. We were giving testosterone to women with masculinization, a lot of side effects for men. And we now know that there may be a mortality risk to being treated with testosterone. So in the 1980s, it was a magic time for molecular biology. There had been a lot of data regarding erythropoietin in animals without kidney disease, with anemia, and it was known by bioassays that there were large circulating levels of a substance that could induce red blood cell synthesis in experimental animals or in vitro situations. And about that time in the early 1980s, there were autoanalyzers that were developed which could take a peptide, if isolated, and delineate the amino acid sequence. So in a series of experiments, mostly done at the University of Chicago, the erythropoietin was biosynthesized from the urine of patients with aplastic anemia. So they used chromatography and differential centrifugation, fractionation to isolate the erythropoietin, confirmed by bioassay that it was active. And later they were able to use that purified erythropoietin in a peptide analyzer to develop the amino acid sequence. What's really amazing is after only a few tries, knowing the amino acid sequence and putting together oligonucleotides that were associated with the amino acid sequence, two groups were able to sequence the gene. One was the Chicago group, a paper by Jacobs and Miyake in Nature in 1985, followed by a really, really important paper published in PNAS, headed by F.K. Lin, who was a relatively unknown scientist from Amgen, in which the genetic sequence was isolated. And it was a corporate paper. It had many employees of Amgen. F.K. Lin was an Amgen employee as well.
Amgen then being pretty much an unknown company, is that right?
Correct. Correct. I mean, it was a molecular startup. The giants in the field were Cetus and Genentech at that time. Genentech had a success with using the same kind of process to synthesize humulin, which became available in 1982. But Amgen was relatively unknown, especially by nephrologists.
To isolate the protein, and which, as Paul says, they were able to sequence, and then subsequently Goldwasser offered this to Genentech and Amgen, and Amgen was the one he selected for this project to try and clone the gene. There was a certain element of good fortune, but it was on the background of a huge amount of work that Goldwasser and colleagues did at the University of Chicago that I think deserves mention. And of course, the work of Miyake also bears recognition because he worked very hard. And they published this paper in the Journal of Biological Chemistry that with the sequence for the protein, which I think was the real foundation stone for how erythropoietin was discovered. There is one other thing I would just add to Paul's narrative, which is that the Amgen was such a small company, it couldn't afford to really develop erythropoietin completely for global marketing. It sold the rights for erythropoietin used in chronic kidney disease patients to Janssen Cilag or Johnson & Johnson, and in Japan to Kirin breweries. And the reason this is important is that the differential marketing of erythropoietin between Amgen and J&J continues to this day. Amgen then developed an analog, a longer-acting analog of erythropoietin Aranesp to use in patients, largely in patients with chronic kidney disease not on dialysis, while they continued their marketing and use of epoetin alpha or epogen in dialysis patients. Very interesting.
Can I get back just
Yeah,
for
go
a
ahead.
second to give a little more numbers to what it was like before EPO got introduced? 15% of the dialysis patients in the US were getting a transfusion at least once every 3 months. And about 5 to 6% were transfusion dependent, which we generally considered at least 2 units a month. And so we had this population of patients, about 5 to 7%, who were severely iron overloaded from their transfusions. And conversely, were severely anemic still. They still had hemoglobins in the 7 range. Many patients make some endogenous EPOs. The remaining patients who were not transfusion dependent had hemoglobins generally in the 8s to 9s. And that becomes important when we get to the introduction of EPO, because it was not introduced in the general population initially. It was targeted at these severely severely anemic patients who were transfusion dependent.
Yeah, so a couple of themes have already emerged. One is the corporate competition between Amgen and Johnson & Johnson, which was spawned very early on in this development, and the ultimate development of recombinant EPO. So, Paul, why don't you let's fast forward a bit and take us to what happened exactly at that Capri conference and the initial study that got everybody so excited?
It was very exciting. Eschbach showed basically the two figures that were prime figures in the New England Journal paper that was published about 6 months later. And it was a very small study, 25 patients. The average hematocrit was about 19.4%. And what they did was they used a range of EPO doses from 1.5 to 500 units per kilogram. 1.5 really didn't have much of an effect, but 500 units per kilogram had an astounding effect that you almost never see in biological systems. It was like a rocket coming off a launching pad. And so the hematocrit could go very high, and potentially in patients, there might be no limit.
So, Daniel, tell us about what life was like before and after, immediately after the introduction of recombinant erythropoietin.
Well, before we had erythropoietin, about 15% of patients were transfusion dependent, and about 5% of those would develop severe life-threatening hemochromatosis. So when EPO was introduced in about 1990, it was really life-changing for patients and for nephrologists. We eliminated transfusion dependence within 1 year, despite the fact we were only giving it to people who were severely anemic and needing transfusions. And we were only giving 10,000 units a week to these people because that's all the government would pay for. We eliminated hemochromatosis. The patients who had it quickly got better because we could drive up their hemoglobin, and they got iron loss with dialysis. The mortality fell from about 265 patients per 1,000 patient years to about 240 in 1 year. And the US hemoglobin in the dialysis population was still less than 10 grams per deciliter.
Wow, interesting.
This was important in the first article that was published in the New England Journal in January 1987. There were complications of high blood pressure, seizures, clotting, and one patient out of the 25 died of hyperkalemia for unknown reasons. And the complications were clearly dose-related. So if we have to talk about whether the problems with erythropoietin and ESAs were apparent, they were apparent from the first clinical reports.
So even if you look at the clinical basis for which they did the subsequent and the first large outcomes trial, the normal hematocrit trial, while everybody emphasizes the thought that higher hemoglobin would reduce cardiovascular events and deaths, there was clear statements in the proposal that maybe the opposite's true, that maybe all of this hypertension and thrombotic issues may actually lead to worse outcomes. And that was the basis in part for doing the study. Certainly not emphasized, but that certainly was a reason to do the study.
I'm reading from the actual study, side effects of recombinant human erythropoietin. To date, we have seen no evidence at the doses used of cardiac, pulmonary, hepatic, or other organ dysfunction that could be attributed to the treatment. We've seen no changes at any dose in the white cell count, et cetera, et cetera.
Right. Those are laboratory measurements, but
Yeah.
and having seizures, that's not a lab report.
Yeah.
Can I just point out that, firstly, the study was on 25 patients. I don't think that as you know, and it wasn't controlled, and there were very rapid rises in hemoglobin, which sort of first caused, I think, of concern whether rapid rises of hemoglobin could be important. But I agree with Dan that I don't think reading that paper you could conclude that this was a risky therapy. I think you would conclude that it was a therapy that provided a huge opportunity for patients who hitherto had been transfusion dependent with iron overload state that was very debilitating, and this was a breakthrough. So
I don't think the question is risky. I mean, I think you're right, but I think the question was that high doses, and it wasn't the rapidity at that time, that's a much later concept, but that high doses could be associated with complications.
I'm someone who is still, unclear in my own head, even though I published on this, that there's definitive proof that it's high doses rather than high hemoglobin and rapid rise. That there isn't a definitive study that has clarified this. There's data to support that high doses might be important, but I don't think we can conclude that from that ESPAC paper.
Well, okay, but let's go forward a bit to less than 10 years later, when Tony Bessarab and others published the study, The Effects of Normal as Compared to Low Hematocrit Treatment with Erythropoietin. What can you tell us about that, Paul? That study, which was 9 years after the original paper by ESPOC.
I'm happy to start that discussion, and I know that Ajay and Dan will want to chime in. I think it was a eagerly awaited paper because Tony had reported the start of the trial at the ASN and really across the United States and different lectures. And I think, as Ajay was suggesting, that most people felt that the outcomes would be salutary. There were cardiologists who were talking about benefits of erythropoietin on heart function, regression of LVH. Subsequently, those studies, when performed as RCTs, were not documented to be beneficial. But I think everybody thought it was going to be a positive study. And it was shocking. It was shocking to the investigators. I think it was shocking to the academic community that basically the normal group, and they were really shooting for very high hematocrits. It was 42% was the normal group that they were shooting for. And the study was stopped early by the DSMB. The New England Journal paper, I think, was particularly difficult to read because there was long-term interaction and arguments between the investigators and the editors because using a log rank test, the Amgen investigators, Tony Bessarab, were suggesting that there was increased mortality in the high hematocrit group. And the New England Journal statistical consultant said, accounting for stopping rules and loss of power, that there was no difference in mortality, but it was futile to show that there would be an improvement at that point in the trial. Anyway, it was a difficult paper, and I personally found it shocking because I think, as Ajay was suggesting, just about everybody thought that there would be a salutary effect. I wonder what my colleagues think.
Yeah, so I mean, it's important to note that firstly, these stable hemodialysis patients had underlying risk. They had a history of ischemic heart disease or heart failure, and some people had argued that, well, this study was not typical of the sort of patients that we see on hemodialysis, and actually that is not correct. We have a fairly high burden of cardiovascular disease.
Half of the patients.
Exactly.
Half the patients would fit this criteria to get in this trial.
Yeah. So there's a significant burden of cardiovascular disease among our patient population. Indeed, if you look at the USRDS data and compare it to this paper, there isn't a really big difference in the characteristics of the patient. So that's generalizable. I went back and looked at review articles that were and opinion pieces that were published in and around this time, and an influential voice at the time is a person called Ian McDougall, and he published a review article basically completely rejecting the findings of the study, arguing that the study results were not statistically significant because they didn't report a p-value that was statistically significant. I think all of that, especially when it comes to safety, has to be interpreted with a very large.
And let's talk about that, though. Let's talk about, so the results that were reported were the relative risk.
Yes.
And they were given as 1.3 for the major outcome, which was death or heart attack. And the confidence intervals they reported as 0.9 to 1.9. And maybe this was arguments about statistical thing. What it clearly violates is transparency. We want to know all the results. We want to know how you cook the results in every fashion. But there were many other things about the paper that in retrospect, when you look back on, are really astounding. They said that there was an increase in vascular thrombotic events, and then listed 4 other thrombotic events that they said were not increased. But in fact, the predefined plan was to combine those other thrombotic events. And in fact, when they were combined, when the study was stopped, thrombotic events in the non-vascular access related types of events were significantly higher. So they split them up into 4 groups to take away the power to say that it was significant.
And in fact, just to point this out, can I just say just a
Yes.
couple of things? A number of my colleagues and I got access to some of this, and we actually challenged Amgen with regards to these results, and I think that Dan is correct. I think that if you look at the clinical study report, which was not originally released, and scrutinize it, there were aspects of that were not shared publicly, which I think is a disservice to the scientific community. I do think that, for example, the dose and the influence of ESA dose in that study was not adequately described. The use of iron was not adequately described. And there were many other aspects of it.
I want to emphasize, just as I started out the discussion by thinking about what a dialysis patient endured in 1985, I think we've made incredible strides in clinical trial science and clinical trial statistics. And that in 1998, the statistics were not advanced enough. There was an argument between the New England Journal regarding stopping rules and how much power you lost, and the investigators using relatively simple statistics. And the paper, because I think of the arguments between the investigators and the editors, which we're all familiar with, turned out to be a bit of a muddle.
Let's not.
But I don't think it's fair to say that it was any one. Papers are published by authors under the scrutiny of editors and reviewers. I do think that the community was poised to interpret these results in a way that minimized the notion of risk. And if you look at this from the perspective of practice, it didn't change practice one twat. Yes, there was a black box warning that was introduced by the US FDA, but did it change
until
practice patterns? Not
2007.
much.
Yes, that was significantly later. But I think it's
let's not forget that the other part of this study was that quality of life assessments, and there was no statistical improvement in most of the quality of life assessments.
The key one, though, has always been physical functioning. So not all quality of life assessments should get better when you're treating specific types of diseases.
But
when we treat anemia, we think that the physical functioning should get better. And the paper had a very misleading statement that was taken because it was the only statement about quality of life that physical functioning had improved in the trial, and therefore targeting higher hemoglobin did have a benefit. It was not until 2012 when I published the results from the clinical trial report, which I obtained from the FDA through a Freedom of Information Act, that in fact there was zero change in quality of life. It's shocking.
Right.
And so it was misleading.
Physical function is a subscale. And I think you're right, Dan. It was misused. It was a poor quality of life indicator. And I think the editorial that Ajay mentioned by Eschbach and Adamson is responsible for the fact that clinical practice didn't change. They basically talked about goals of 33 to 36%. They didn't say it was a negative study. They didn't say high dose might be associated with risk. And shockingly, they didn't mention anything about conflict of interest. I know that's an interest of yours.
Yes, the paper does mention, the Eschbach paper, that they were stockholders in Amgen.
Yes.
Most of the authors were. Well, let's move.
I think one other thing about, I don't mean to badger this, but one other thing about the paper is, and we'll come back to this in 2007 when the FDA comes out with their reanalysis.
Right.
The paper makes very clear that they did not find any relationship of EPO dose to worse outcomes. Move forward to 2007, and the analysis by the FDA is we didn't have any problem finding it. And it's present in patients who are getting exposed to 20,000 units of EPO per week or more. And they analyzed the same data.
So let's move ahead to the subsequent clinical trials, which took place several years later, the Choir, Create, and subsequently the Treat trial. What did they show, and how did they, if anything, alter practice among nephrologists?
Well, I can get started. The Choir study was a study that was that recruited patients with chronic kidney disease who were not on dialysis. It was an open label study, and it had 1,432 subjects enrolled, split evenly. One arm was targeted to get a hemoglobin up to 13.5. The other, the lower hemoglobin of 11.3. The study was for a median period of about 16 months, and it used, like many of these other trials, a composite endpoint of death, myocardial infarction, hospitalization for heart failure, and stroke. And basically it showed, remarkably, it showed a hazard of 1.34, remarkably because it was very reminiscent of the similar effect seen in the normal hematocrit trial. And here the nominal p-value was 0.03. In the same issue of the New England Journal, there was another study published called the Create study. It was a smaller study. First author was Tillman Druke. These were stage 4 CKD patients. It was 603 subjects. These were patients with mild anemia, and they used subcutaneous erythropoietin. And the primary endpoint was a composite of 8 cardiovascular endpoints. They also looked at left ventricular size, quality of life, and progression of CKD. In this study that they published, they said they didn't see a definitive result, that the result was null. I think that there were these two studies back to back, published in the same issue. The results from the Choir study, I think, ultimately were more influential in terms of changing practice. Certainly, as Paul mentioned, in 2007, there was a black box warning around it. In and around this time, there was a flurry of lots of concern about conflict of interest and whether there was overutilization of erythropoietin. I'm going to stay away from that unless you want to go into it. But essentially, the results showed that in both dialysis patients and non-dialysis patients, there was increased risk with raising the hemoglobin while high doses of erythropoietin. Subsequently, Linda Sezik and a number of us, including me, published a paper in Kidney International where we used the landmark analysis approach to try and associate EPO dose with outcome. And we suggested that there was an association. But I would hasten to add that once you do observational studies, they are also limited by effects of confounding. And given the fact that hemoglobin and EPO use are linked with each other, it's often hard to separate the two.
Yeah.
So the debate continued.
I will say a few other things I want to add. Create didn't carry much weight because it was only 603 patients. And in fact, there were more cardiovascular events in their higher target arm. It was an underpowered study and actually healthier patients than had been in the larger Create trial. Choir did have an important effect, Ajay, on clinical practice. If you looked at patients starting dialysis at the time your study was being completed, about 30% of patients were getting an ESA to raise their hemoglobin above 10 at least prior to starting immediately prior to starting dialysis. With publication of Choir, that started to erode and steadily came down, and now it's well below 15%. And in fact, within 4 or 5 years, it was down about 15%. We're only getting ESA in the pre-dialysis era or in the pre-dialysis period.
In the interest of time, can I just quickly mention that around that same time, while Choir results were coming out, I was on the executive steering committee of the Treat study. So we shared the results of the actually at that time confidential results of Coyne with the TREAT Executive Committee. This study was a randomized control, placebo-controlled study, and it sought to look at a very high-risk group of patients. These were patients with diabetes and kidney disease. And I think the two studies combined really raised the spectrum of safety concerns. And in fact, around that time, KDIGO guidelines came out on anemia and suggested that nephrologists be more cautious, not only about correcting the hemoglobin, but also using anemia treatment like ESAs in patients who have underlying cancer, active cancer, or a history of stroke. I think that these studies collectively demonstrated that there was an increased risk. Now, the question I wanted to ask my colleagues is: are we still convinced that this is a dose risk effect? Because more recently, in the HIF PHI studies, where you use an agent, a drug to stabilize HIF and cause increased synthesis and release of endogenous erythropoietin, there's no difference. They're non-inferior outcomes when you use a HIF inhibitor compared to exogenous ESA. So I'm not 100% sure in my mind that ESA dosing and normal levels of ESA dosing are associated with increased risk. I think, to me, the point is that in these early studies, whether it was in Coyne or in normal hematocrit or in the EPOch study or the others, very high doses were used, whereas I think practice has since changed, as Dan pointed out.
Well, what about the hemoglobin target? Is that the culprit here as opposed to the dose?
I just want to go back, and that might answer your question, Andy. I think for a general medical reader, for a clinical nephrologist, the impact of the Coyne and CREATE together in the New England Journal said definitively that there was no clinical reason to go for a higher hematocrit.
Right.
And I think that was a really solid conclusion. One of the things that I'd always felt before Coyne started, before CREATE started, and no drug company was interested in that, was the trial should have been designed to find the lowest effective hematocrit where you could improve quality of life and not jeopardize length of life. That was the tension between 1998 and 2007. Were you going to balance quality of life, which might have been improved, with length of life, which might have been shortened? So I think that the study suggested that you paid a price that was not worth it for higher hematocrit goals.
So we have these three studies: the Coyne, CREATE, the TREAT study over a span of 3 years. What was driving this increasing dose of the recombinant EPO? Was it simply that nephrologists were trying to get best outcomes for their patients? Were there other incentives that drove this process?
Let's go back. So Ajay presented his data in April 2006 at the NKF meeting. And this was the preliminary data to Coyne, so we could all get the first look. The next day, the KDOQI work group announced that the hemoglobin goal target had been raised from 11 to 12 to 11 to 13. And that this goal range, in fact, was a clinical practice guideline, not just an opinion based on them. And they claimed that this was due to a compelling improvement in quality of life in the available data.
This chain of events, these decisions and practice guidelines, what do they tell us about the influence of big pharma and the response of the nephrology community?
Well, I think in 2006, there was far too much influence on the guidelines. And by 2007, they had to roll back that. What was a driver at that time was was incentives in the dialysis market for profits. And so we had this perverse incentives where government was not paying us enough to dialyze patients, and profits on drugs became a major way of making your profit sheet look good. In fact, if we look at DaVita, the second largest one, which we had data on at that time, 25% of all the money they were making was coming from using EPO. And according to one analyst, it represented 44% of their profits. They had a compelling reason to want to see even higher use of EPO. And the guidelines released in April of 2006 by Kadoki raised the hemoglobin target. Your hemoglobin's where it is. You want it to go higher, you're going to have to give them more ESA. Second thing is that they actually recommended not giving patients any iron if they had a ferritin above 500. At the time, the average ferritin in the population was about 600. So this would mean that most patients would have their iron placed on hold. And there is this yin yang. The more iron you use, the less EPO you use. And conversely, if you restrict iron, you're going to wind up having to give your population of patients more EPO. So those were clearly going to drive up the amount of ESA use. And it's hard to reach those clinical practice recommendations if you follow the available science in 2006.
Dan, you really very elegantly in your editorial on Cotter's and Kaufman's paper in JAMA, which talked about little response on a population level of hematocrit to higher EPO doses, perhaps because of iron deficiency, perhaps because of resistance, in how they had conflicts of interest in the approaches. Both you and Ajay in congressional testimony talked about standing orders, which Andy has mentioned, that the large dialysis organizations used to manage erythropoietin and ESA drugs to maximize doses and therefore maximize profits to corporations and to dialysis companies. So I think those were very, very elegant opinions and important opinions, which I think were ignored, except for perhaps some government.
I want to give credit where credit's due. So first, I agree with you. The Cotter and May Thamer was the first author on that JAMA paper, clearly showed that commercial dialysis units, in particular one large unit, which they identified as Unit 2 or Chain 2, were using far more EPO than anyone else and driving hemoglobins higher. And they had the very strong incentives to have it go even higher. Non-commercial units, I think, were fairly reasonable and continued to restrict it. And it's after 2007 that we really see the separation. Clinicians, nephrologists control who gets ESA in the CKD clinic. And as I mentioned earlier, the average nephrologist was treating less of their patients and treating them to lower hemoglobins. So when they started dialysis, they were less likely to be on ESA and they had lower hemoglobins. What didn't change until 2011 when we became bundled was dialysis chains behaving in that fashion. I think the simplest explanation is that's all driven by our misplaced economic model, which made drugs profitable, and that's not a good way to manage patients.
Well, let's not forget that this was all being financed for the most part by the federal government, by Medicare. So to what extent was Medicare, in a sense, a co-conspirator in this process of driving up the use of EPO?
I think they were pretty big one, because they had to basically allow these values. From an FDA perspective, they all long thought that their initial statement that the hemoglobin ought to be 10 to 11 was a pretty good goal and it shouldn't change. What did change, though, and including in the package insert for a period, was a great deal of lobbying going on by various organizations.
So in my book, I wrote that the government was paying for poor results and perhaps killing patients. And that is really unfortunate when policy is not informed by the best science.
And this has implications. This has much wider implications. I mean, we have the whole discussion we've had in this country over the last decade or more about national health insurance or Medicare for all. And while there are certainly benefits to having federally funded health care, there is also this danger of misused, misallocated appropriations. So that's one thing to take away from this. Well, let me just ask you, as in summary, what would you think about this in terms of wider implications for nephrologists, for the nephrology community, and what do we take away from the lessons of how EPO was rolled out?
Well, as a clinician and a scientist, I feel one of the major messages is that we should be aware that we live in a capitalist society and that corporations are set up to maximize profits. I think that it's incumbent upon every prescribing physician to weigh the risks and benefits. I know one of the questions that you've been interested in is how has the regulatory landscape changed over the last 40 years? And I think it's changed by bringing patients into the mix. I know that Ajay has experience with that kind of patient voice at FDA meetings. I think that basically sometimes patients can be corralled into supporting corporate positions, but I think the one of the lessons of the growth of erythropoietin and ESAs is that the patient-physician relationship is very, very important. Patients have to be told that if they would like to pursue, for individual reasons, higher doses of EPO to try to get higher hematocrits to improve quality of life, they may be caused to pay some price for that. And I think in congressional testimony, both Ajay and Alan Kleiger made that point, that one shouldn't have just guidelines based on what the hematocrit is, what the iron is, but everything should be positioned on a good clinical relationship with a patient who's informed about risks and benefits. I know it might sound kind of pious, but it's a great way to practice medicine, to have the patient aware of what the patient is going to receive as a drug. That's my take.
This podcast should not be used in any medical emergency or for the diagnosis or treatment of any medical condition. If you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment, please consult your doctor or another qualified healthcare professional. Views expressed on this podcast are those of the speakers and not necessarily those of the American Society of Nephrology.